Good afternoon, everybody. Happy holidays and welcome to the December Transformation Talk. My name is Maria Corrigan and I'm the Special Assistant for Systems Transformation here at the Department of Health. I am really excited about today's presentation about the Diamond Project, which is we're focusing on how we are working together as a governmental public health system around issues related to immunization. I saw this presentation, or at least parts of it, I think, at the meeting in earlier this year at Washington State Public Health Association meeting, and I thought it was great. I myself am sort of buried in foundational public health services work, and there are definitely lessons learned from this project around how we are thinking about new service delivery models and working together as a system. So again, very excited. We have with us a number of people today who are helping us with this presentation. Michelle Roberts, Doreen Hirsch, Stacy Wenzel, and Susan Gizzi. So I am going to hand it off to them. Michelle, I think you're first up, so take it away.
Great, thank you, and good afternoon, everybody. This is Michelle Roberts, and I'm the Immunization Director here at the Washington State Department of Health, and we really look forward to talking with you about the work we did together as a collective state and local public health community, and share our lessons learned and hope that we could spark some ideas about how other collaborative projects within the governmental public health system could potentially continue to discuss about how we use limited resources and how we partner and work and continue to move forward as a system. So, like I said, I'm on the phone. We have Doreen Hirsch, who works at Public Health Seattle-King County and was the lead from WSALFL, the Washington State Association of Local Public Health Officials, and kind of my co-sponsor on this project. Doreen will also do part of the presenting. And then we have two of our fabulous facilitators on who both work for two local health departments, but in this work as our facilitators, we're representing the Centers for Excellence, which is a fantastic resource we have here in Washington State that can help do quality improvement projects. So that was Stacy and Cinden's role on this project. You'll see we're using their slide deck set, so you'll see the address if you want to learn more about the Centers for Excellence and that resource here in Washington State. So let's go to the next slide. Just really quickly, as far as what we're going to cover today, we're going to talk about like what was the background and what was going on and why we started this work together. We're going to talk some about the process we went through to really do some collaborative decision making. And then we're going to go into some of the evaluation findings from the evaluation of our work together of this project. So not talking about the evaluation as we've been implementing, that's still to come, and I'll give a little bit about our evaluation plans moving forward. And then we have time for question and answers and discussion. And we really would love to hear from people on the phone or who are listening today about how this may help apply to other public health systems and services and our work as a collective governmental public health system. So next slide. So like Maria shared, this project really came together to focus on 7 of the 8 tasks that are in the Department of Health local health jurisdiction consolidated contract, and that's kind of the big master contract between state health and local health in our state. And there is, we contract a body of work from the state to local health within that contract. And there was 8 tasks that were for all 35 local health jurisdictions in our state. And this project really focused on 7 of those 8 tasks. You can see the list there. It's really important to note that all of these tasks are coming from our federal grant. So they are CDC requirements in the federal immunization grants, and they all have pretty strict guidance. The other thing is most of them are focused on accountability work around the federal Vaccines for Children program, and was very limited focus on activities to increase immunization rates. Next slide. So that project or that work that was in the consolidated contract had been decently static for many years. And there was a ton of challenges. I think there wasn't a lot of want to dig back into really, is this the right work? Are we using our limited resources the right way? what are the challenges, because I think everybody was feeling really protective, period, of the work, and that, you know, it's important for all levels of the government to do pieces of this immunization work. But the work had really significantly changed, and we were pretty behind in figuring out the contract work to make sure was it aligned with how the work was happening now. CDC grant requirements had also significantly increased. An example of that is that instead of doing a site visit to all clinics who get state-supplied vaccine once every 4 years, we now had to visit every clinic once every 24 months. So, and there was no new funding as CDC grant requirements changed. It was also, there was a lot of new ways in how our business was happening, and an example of that would be vaccine ordering. So vaccine ordering to get state-supplied vaccine used to be a paper-based process. And over the years, it had moved to electronic ordering. So there was a lot less need for staff time to do that work. And like we used to have vaccine depots at the state in every county where they actually had vials of vaccine that got shipped to them and then were distributed. And that was a really old model that wasn't happening anymore. Vaccine was shipped directly from a central depot to the provider offices. So there was a number of things happening in the system, and this increase in requirements, and really everybody from every end, local health and state, feeling like there was just not enough resources in the model we have to do the work, and it was leading to a lot of frustration. I think having all 35 counties touching really specific CDC requirements as well led to a lot of lack of standardization. And for some of the smaller counties in our state, they were doing some of this work on a very infrequent basis because they may only have 4 providers in their state or in their county, or less than 10. So they weren't doing very many site visits or immunization improvement rates. So it was really hard to keep staff really up to date and feeling confident in that work. So there was just a lot of challenges from everybody's perspective, and I think a number of people were feeling that things are really broke. So that's why we went down this road to work together. So next slide. From the beginning, as we kind of started this work and started in partnership between us and WSALFO, we were really clear that there were a number of constraints or kind of boundaries in the work to help us make sure we understood what the playing field was. And a few things were that any planning work we did together still had to meet our federal CDC grant requirements, which we don't anticipate to change. And since they are about safeguarding the federal vaccine program, there's really just not very much flexibility there. So we also were feeling that there was probably very likely not going to be any more funding to support these activities. So just that, like, the funding we have is the funding we have at this point. And there was a hope from the beginning. I talked about how most of the work we were contracting to local health was really focused on kind of accountability work and seeing our providers, how they're ordering vaccines and how they're storing it and counting the number of doses, and not really focused on work to increase immunization rates. And this was the only funding as a state immunization program we were contracting to local health for. And it was really, I thought, a missed opportunity to help local health to be able to use some of that limited funding on activities to increase immunization rates, which for a lot of reasons, the best way to do that work is often going to be at the local level because they're going to understand their communities, have the right partnerships, know where the challenges and the opportunities are. So when I came in as immunization director, just continued growing discomfort for me that the only funding we were putting out was tied to accountability for the most part, and not about improvement on our ultimate outcome, which is increasing immunization rates to protect people from diseases. So I'm going to hand off to Doreen for the next slide, and she's going to talk about how we came together.
Thank you, Michelle. At the time, I was the president of WSALFO, and Michelle called to talk to me about this unsustainable system that we had going on in our state and how we could better support and partner. Public Health and DOH have had a lot of successes with using lean process improvements, and the Department of Health actually had a QI facilitator on staff. So we did a couple rounds of facilitation with the DOH resource, and then unfortunately that person resigned. So we ended up contracting with the Centers of Excellence, which actually was the best decision we made. And it really, hopefully it's ensuring our project success. One of the things that we were told to do, or partnered to do, was to develop specific team roles and responsibilities. We had sponsors, one from GOH, one from WSALFO. There was project leads identified. That was a Department of Health staff person. We identified project team members, and this was both local public health and Department of Health staff. The cool thing about this process is that we actually had people who did the work, so they were really, really close and had the best ideas on how we can improve our systems. And we also had some supervisors. And the most important members were our project facilitators from the Centers of Excellence. The Diamond Project was named because one of our members decided that this was a new way for us to engage. So then she started thinking about engagement rings, and hence came the name, the Diamond Project, named for an engagement ring. Next slide, please. Okay, so we worked together, we defined our project goals. We're focused on standardizing the work that we did across the state because there wasn't standardization at this point. And our hope was by gaining efficiencies, we could rededicate resources to work on increasing our immunization rates across our state.
On this project was to be one of the lead facilitators. And I can say, in all honesty, it was a privilege to work with the people that came to the table because of their commitment to work through this huge change. So if anybody's on the phone that heard us talk at WSPHA, I can talk about quality improvement methods and tools forever. I'm going to do an abbreviated walkthrough of the process that we guided the team through. The slides have a lot of information, so I would just encourage anybody that if you have follow-up questions or want to get really geeky with the methods or tools, follow up with Cindin or myself, and I'm sure we'd be happy to talk through those with you. So the main takeaway for this first slide is just to enforce that this was a huge project. It wasn't a simple one process improvement, tweak it and move on. We're talking about transforming 7 different major service lines and how they were happening in the state. And so the first thing that we had to do is really think through how to put this work out in bite-sized chunks so people feel like progress is being made, and to provide some context and parameters of how we can work together. So for this project, we broke it up into the phases that you see on your screen, starting with an assessment. So in that first phase, we really wanted to make sure that we had agreement on who was the customers, the main customers of these 7 tasks in the VSC work, and what did they need. In that phase, we also did some just team roles and kind of laying the groundwork. After we made some initial high-level planning or assessment, we moved to a planning and setting priorities. So knowing that not all of the tasks were going to be done the same way, we needed to kind of prioritize how those were happening. And that led to some pretty major recommendations that I'll talk through next. And then we moved through quality planning cycles where we looked at each one of the specific tasks and details, and then kind of closed out in phase 4 and prepared for a transition and a new way to do the work. Everything that we did in every phase, we embedded the principles of quality improvement. So starting with who's the customer and what do they need? Relying on the team. We had a committed bunch of folks who were at the table, actively engaged, and we relied upon their wisdom to kind of help guide those recommendations. We used data and evidence, and we followed the QI method. So one of the key principles of QI is the bigger of the projects, the more reliance you want to make on the methods and tools of quality improvement. Next slide, please. So for the first phase, again, after having the last facilitator resign, there was a little bit of a lapse in timeline. So we had to reconvene the team, reestablish commitments. We worked very intentionally on building trust and transparency in the team, developing a charter and make sure everybody was on board. We identified the stakeholder and the primary customer, and the primary customer for the project was the providers who actually experienced these services and the work. And then we did an assessment for their needs. And then from there, we worked on identifying, well, what are all the options or the ways that we can get the work done? So that was kind of the broad work that was done in phase 1. Next slide, please. Some of the key findings from the Voice of the Customer highlights. So we looked at LHJ leadership in the assessment process. We also surveyed the LHJ staff who were hands-on doing the work, and we also surveyed or spoke to the healthcare providers. So we gathered information from those three perspectives to provide kind of that balanced viewpoint. Some of the highlights that we heard. LHJs were very keenly interested in exploring cross-jurisdictional sharing. I think we're all in the position of knowing that we can't continue to work the way we have been. We have to look for new ways of doing things. The major concerns that surfaced in the LHJ leadership surveys were concerns about funding, of course, but also that LHJs were able to maintain their positive relationships with providers. That came out as very important. We also heard from the LHJs that there was a substantial amount of confusion about roles and responsibilities. You know, as an LHJ, is this my job or should DOH be doing that? And that all surfaced inefficiencies is really what that highlights. And then we heard a little bit about recommendations the LHJs have for if we're able to do new work to actually increase immunization rates, what would that look like? From healthcare providers, we heard positive experiences with both phone support and email support from DOH and LHJs. We also heard frustrations and challenges with reporting through the IIS, which is the technology platform, which was a bit out of the scope of this project. And we heard about some challenges with receiving vaccines. I'd also say that we heard a little bit in the comments, even though it didn't rise to being a major theme, that to some extent providers didn't really understand nor necessarily care about the difference between LHJs providing the services or DOH. What they really care about is that their needs are met when they have them. Next slide, please. So a major component of this first phase happened at our first in-team meeting. So we had an in-person meeting where we gathered the whole group together for 3 solid days. And what we needed to do was establish a couple things. We needed to talk about what were the options for doing the work moving forward. So what were we willing to consider? So based on the discussions about where the tasks were and the problems that were being had, and based on the input received from the assessment, the main options that were identified for doing the work moving forward was, one, that DOH could take over doing all the work at a centralized level. The second option was we could totally decentralize it, which is the way it had been, that the LHJs could keep doing work at the LHJ level. And or 3, the third option was that we could talk about doing shared services. So cross-jurisdictional sharing, figuring out a new way of working together. So those were the 3 options that were kind of surfaced and identified. Then we worked with the team to identify criteria against which to evaluate those options. And the way that we did that was simply questioning in small groups. They did small group brainstorm, answering the 3 sets of questions that you see. So what words would characterize or define work that's best done at a centralized or state level? And then in contrast, what words would characterize work best done at a local level? And then third, what would support or define work that's best done in a shared manner? Once we established those criteria, so small groups brainstormed them, we synthesized, we refined and came to agreement, then we actually used those criteria in a matrix, so a scoring, a systematic scoring method to score each of the tasks against the criteria and look at those options. Next slide. So I'm not going to read these to you, but we do think that these criteria sets might be of interest to other people wanting to do similar work. And so this is what the team came up with as work or criteria that best defines work done at a centralized level. So work that needs really highly specialized expertise. Work that can be done remotely would qualify for, you know, best being done at a centralized level. High overhead, need for standardization. So some of those are the criteria that were used or should be used to describe centralized services. That's what the team came up with. Next slide. So decentralized, so services that need to be done locally at the LHJ. So some of the criteria that the group came up with was when the LHJs need to maintain local authority. when there's specific and intimate knowledge of the communities and the local community context, when geographic proximity is needed, so when you actually have to be present in the facilities. So those are the criteria that were used to evaluate the work to be done at a decentralized level. Next slide. And finally, kind of the new way of doing business. Well, which criteria describes work that we should be doing together collectively in a shared manner? And so what you see is some definitions of when common goals between LHJs are shared, some degree of geographic proximity, opportunities to leverage partnerships, and then the economies of scale. So those were criteria that were used to then guide the further discussions and weighting of the options and the decisions related to who best does the task moving forward. Next slide. So really the output here was the recommendations. So once we actually developed the criteria, we weighted them, and we applied them to the decision, the key thing that did was really help develop ownership of the results of it. It helps create objectivity within the group process, because we were using criteria that the group themselves had come up with and developed. And the results were pretty clear. And subsequently to that, the recommendations were, it was really easy to come to them, if you will. I think one of the highlights of my time on the project was after that first meeting, one of the participants commented on how easy the decision process was. And I think that just illustrates how important it is to use a quality improvement method and tool, because relying on that tool really helps make sure a systematic process is happening and objectivity is maintained. So what you see in front of you is the ultimate recommendations that were made by the team and ultimately adopted by DOH after a vetting period. So it included delivering new services focused on childcare and schools that should be done locally, and then working to develop a cross-jurisdictional, a new model for doing the work for tasks 2, 6, and 7, and then any new work related to provider-based interventions. And then interestingly, it was pretty unanimous that the group agreed in this decision matrix that tasks 1, 3, 4, and 5 should just be transferred entirely to DOH to be done at a centralized level. Next slide. So here I'm going to hand it over to Sinden, because at the output of these recommendations came a very intentional vetting and communication process that Sinden will go into.
Thanks, Stacy. So I had the privilege of working on this project, and I focused time on communication planning and risk management planning. So I'm just going to talk briefly about what the team did in these areas during phase 2. And then I also, before I go into that, Stacy mentioned that I'll talk a little bit more about the process for vetting team recommendations. So, for example, these are the recommendations that were listed on the previous slide. And the team, the process that we use to vet and make final decisions based on those recommendations included the team analyzing options and coming up with recommendations, which you just heard from Stacy. Then those recommendations were vetted by the sponsors, so WSALFO and DOH, represented by Doreen and Michelle, and with then the Department of Health and local health jurisdiction stakeholders. We would then collect that, any feedback, we would document the input, discuss it with the project team, and talk about if any of the feedback that we're hearing changed their decision, made them think of different things or look at the criteria in a different way, and if they wanted to change their recommendations. And they would have that discussion, make a final recommendation, and then the final decision was ultimately made by DOH. And again, we were very explicit in the beginning to share this process and make sure that everyone understood that the final decision did lie with the State Department of Health. so that was again, the process that we used to vet team recommendations. So now I'll go back up and highlight the communication planning that we did. We use strategic communication planning, a tool and template. And so what that means is that before we started talking about stakeholders and audiences and tactics and how should we message and what should we message, we started with a very strategic view of the project. We did a situation analysis. We did a SWOT risk analysis to identify strengths, weaknesses, opportunities, and threats for the whole project. And then we identified communication goals and objectives. What high level, what was the team trying to achieve with communicating this information? And then we went on to what I think most people are familiar with identifying your key audiences, developing messages that were different per audience, coming up with tactics such as emails, peer-to-peer communications. We had other one-page recommendations, one-pagers, fact sheets, things like that. So that's basically how we did our communication planning. And again, it involved the entire team coming up with and helping to develop this communication plan. Next slide, please. The other thing that we did and the other tool that we used was a risk management plan. And so you see on your screen, this was a process that involved the entire team. We had everyone stand up and go to a wall, and on this big blank wall, we put up a grid very similar to what you see on your screen. So, and then we asked the team to rank each threat, potential weakness, any other risks that they came up with, to rank those as low, medium, high, first on how great of an impact would that be on the project if that risk or threat occurred, and then low, medium, high, what's the probability that that threat or weakness will actually occur. And you can see then we've got some green lights, some yellow lights, and some red lights. The red lights, so if the team came up with any threats or risks that fell into those segments, those were ones that we immediately addressed and talked about tactics and how we were going to address those and what would happen if they occurred. The yellow ones, we had some discussion, but we didn't focus on those. And the green, we just kind of kept an eye out for those. And we came back to this multiple times throughout the project. We actually updated both the communication and the risk management plan multiple times throughout the project. Next slide, I'm going to turn it back to Stacy.
Okay. So just to recap, phase 1 and 2 was really about, again, looking at the systems level, breaking apart the problem, and making some big systems level decisions. So transitioning 4 of the tasks to a centralized approach, transitioning 3 to cross-jurisdictional sharing. The key tool there, again, was the decision matrix. I can't stress enough that that was one of the pivotal moments in the team's work together that really cleared the path for making continued progress moving forward. So going into phase 3, at that point was, okay, we've made these big sweeping systems level decisions to change who's doing these tasks, but still recognize the need to improve the existing workflows of those tasks. And the work cut out for them was to design this new cross-jurisdictional sharing model, which hadn't yet been in existence for this body of work. So here we use the methods and tools of quality planning and improvement, and you see the diagram on the right of the screen is the Lean Six Sigma approach to following a QI method. Next slide. So part of the QI method, of course, is using data to inform and guide decisions. And so one of the things that we did is after we mapped the existing current state of each of those tasks in the BFC body of work, we collected data to evaluate more in depth where the inefficiencies were in the body of work happening. So this is just an example of data collection. So the BFC vaccine compliance or the site visits was one of the tasks recommended to move to a cross-jurisdictional sharing fashion. So the team had to decide how is that work going to look moving forward and where were the inefficiencies and how did it need to improve. So to be able to kind of guide that development of that new work, we needed to understand how long those site visits were taking. So time was the main process measure used there. We had the team do a time study by having all of the team members take time according to each of the steps in the process. So all the team members were collecting data in the same way. And we looked at a total or partial 273 records to get the picture of average time. What we found was that the average total time to do a compliance visit at a provider's office was about 4.87 hours. Now, we know, depending on where you are in the state, whether you're, urban or rural, travel time is going to be factored in there. So when we took out the travel time, we found that a site visit, from preparation before the visit to actually on-site conducting the visit to the follow-up work, on average across 273 records, only took 3.47 hours. The contrast there, or the inefficiencies that were being highlighted, is that historically the LHJs were funded at a rate of 10 hours per visit. That's a pretty dramatic difference of over six hours. What we also learned was that there was substantial variation in that process data that I won't get too geeky about, but the average cycle time of a visit was 14.8 days, ranging, depending on where you are in the state and who is doing the work, from 0 days all the way up to 107, and it had a variance of 624.5. So in a nutshell, extremely high variability in process or lack of standardization. On the right, you can also see that we took a look at what was driving compliance issues. So what were the main site actions or compliance write-ups that staff were taking? And we used that data, that's a Pareto, so the 80-20 rule, 80% of the problems caused by 20% of the sources. We use that to really have some discussions about how we might mitigate or prevent some of these errors from occurring and thereby further decrease time in the process. So again, that's an example of some of the data that we collected and analyzed as a team. Next slide, please. All of that work we did to map, process, and collect data fed into redesigning the processes. And so on the left of the screen, you see the team's recommendations, and that came about after a second in-person week meeting. Ultimately, the team recommended that the 9 accountable communities of health regions in the state would serve or should serve as the VFC shared services regions. And then we also talked about some qualifiers to that, how regions should be selected and what is the culture that we want to foster as a statewide team of public health providers. So the group was really concerned about a team-based, customer-centric approach. And then on the right, you can see all of the other work that we produced in this phase was each one of those 7 tasks we went through in detail. We mapped out future states or ideal states of how that work should be done. We discussed where the efficiencies need to be gained and how to actually realize those efficiencies. Next slide. And I believe that's back to Michelle to talk a little bit about how the project then transitioned.
Great. Thanks, Stacy. So in this last phase, after we had done all that great work, we really kind of handed the project back over to the Department of Health staff to move towards implementation. So we did a number of things. We finalized the plans to kind of align this with our CDC grant cycle and to align that within our grant documentation for CDC. We released a process to collect applicants for local health who wanted to serve as a lead in their 9 regional leads. We had to do a lot to get the contract language changed for each of the LHJs in the consolidated contract and working through that process, an administrative operation process. And we also worked on figuring out at the department, building some of the information we had done as a team around what this new body of work could look like that was focused on increasing immunization rates, which we were offering out to every local health department. I think a piece of the amazing news here is that overall for this whole body of work, we were able to keep the same amount of money dedicated to the work as a whole. And we've had some shortages in our federal grant just from increasing costs of doing business and federal funding that's not keeping up with that. And so, but the good news is we were able to keep the amount of funding dedicated to this and going to local health as a whole steady, even though we were making reductions in our office at the state at the same time. So that in the end, we freed up half of the money that was going to local health to spend half on work that would be done in a regional way, and then spend half on the work that was going to be going to all local health jurisdictions to increasing immunization rates. Still a small amount of money. That's definitely not going to meet the full need on work to do increasing immunization rates in a super comprehensive way, but I think really important foundation to our whole health system and some of the work we're doing around foundational public health. So it would be a place to build from in the future if there's more funding available. Something else we had done, Sinden talked about our really intentional work around identifying and mitigating risk. So not a perfect process, but that is, we really were thinking about this the whole time and making sure as we moved through the planning, we were thoughtful about this and thinking about it. We identified a risk as the process moved forward that was a little bit late in the game around that if we were going to be offering this as the work that was going in a regional model to competitively to local health, that we were kind of on the verge of making state contracting rules around not getting input from people or having them help plan the process for people who could be a select portion of the group who may be applying competitively for that funding. So that was kind of something that we kind of missed in our initial planning. And so it really did change kind of what conversations we could have as we were moving towards implementation with the Diamond Project, since that team was just a subset of all local health jurisdictions who might be competing for the funding that would be shared services funding. So that was kind of a change in the process, but I think a really important lesson to learn. One, that we didn't cross the line, so nobody was disqualified for competing. And then I think two, helping us continue to understand as a public health system, really as we do shared work that may lead to funding for some or competitive funding, really hopefully being more intentional in the future about what are the boundaries and are we all on the same page as a system about what those boundaries are. Next slide. And I'm back to Stacy, I think, to talk about some of the work we did as a team to debrief.
Okay, so one of the key things that we felt was really important was to convene the team in a final meeting so all of us could reach closure after having spent so much time and energy working together on this big challenge. So we had an in-person all-day debriefing and celebration that was a lot of fun. As part of the facilitation team, I'll say we put the team through the ringer trying to get every last bit of perspective and information from them so we could know how to do things differently and know what worked really well so we could communicate those successes to others in a position of making similar systematic changes in public health work. So we did a lot of dives into strengths and improvement opportunities. You see some of the highlights on your screen. We took all the information that was recorded and synthesized it. And overall, some of the key factors to the team's success were, number one, a commitment to objectivity. That was a critical success factor and is one of the things that we'd recommend that needs to be replicated in other cross-jurisdictional efforts. From the sponsors to the individual team members, people came to the table willing to be objective and to look at how best the work how the work could be best done moving forward. We also heard from the team members that facilitation was pretty critical and commitment from the participants to be facilitated. So as a facilitator, I wouldn't have gotten very far if people had the end in mind when they came to the table. And I can say honestly, from how the teamwork was set from the very beginning by the sponsors, people were there to reach a good decision, not what they specifically wanted. So people were able to put aside their own biases and do a really good job trusting that process. We heard from the team members that the application of quality improvement principles, methods, and tools was critical. it really helped make sure that the team made effective, systematic progress moving forward. This project was huge. That's why we broke it up into phases. And I think if we hadn't have used a systematic quality approach, we would have easily gotten lost in the weeds along the way. So using those methods and tools was extremely important. A key highlight was that decision matrix. It really helped the team be objective in reaching their decisions. So that was a pretty critical success factor in the project. And then the last thing that the team participants chose to highlight was the executive sponsorship. So throughout the process, having the executive sponsors, so again, that was one, Michelle from Department of Health and Doreen representing WSALFO, was really critical. Having their engagement and having the team see them be engaged and proactive and providing thoughtful guidance and dedicated support, that was observed by the participants and expressed as a key factor in the success of the project. And let's see, along the way, some of the key findings were the risk. So we did surface some critical discussions about funding. And I'd say that, you know, the risk mitigation is never going to be perfect, but it helps move it along. And had we not been so risk and thinking about it and expecting it, things could have happened a lot differently in the project. So yeah. And with that, I think I'm going to turn it over to Sinden. The other aspects of the evaluation that we did was a survey of leadership to get their perspective on how the project went, and some input from LHJ staff.
Great. Next slide, please. So you can see, as Stacy said, we did a couple of surveys in addition to having the team meet in person. Some of the results that we saw from this survey of LHJ and DOH leadership, we asked them to rate how they thought the project went in different aspects of the project. And so you can see on the right side of your screen that we asked them about communication, recommendations, the team composition, and overall project coordination. Now with this scale, low number is good. So you want the number to be low. It was a scale of 1 to 5. And you can see that everything was in the low 2s. So we felt pretty good about that. So it was an average of good in terms of all those aspects. We also asked some questions about how, now that we've gone through this process, how do people feel now about potentially using cross-jurisdictional shared services? And you can see that there was still a large percent of people surveyed, leaders, LHJ and DOH, who were still very interested or somewhat interested in these approaches. And we asked them about the likelihood of recommending this approach to other states who want to design this. There's an error there. I think DOH was not 54.6. I think it was 5.6 on a 10-point scale. So interestingly, LHJ leadership actually felt like they would recommend this to another state more so than DOH leadership, which came as a surprise to us because we had thought LHJs would be much more resistant to the shared services approach. And then just some improvement opportunities. Many of these you've already heard from Stacy with the team brought up. Communication, absolutely, number one. We thought we communicated in multiple ways, at different times, in different ways, and still we got the feedback that we needed more. The most beneficial form of communication that was used during this project was the peer-to-peer communication. So this is when team members who are working on this program back in their LHJ, when they would communicate with either members of their own staff or they would talk to maybe a neighboring LHJ, that seemed to be the most effective, where we were able to really communicate the recommendations and the concepts behind this project. Balancing efficiency and effectiveness, that I think is around the standardization and wanting to be most effective and really, talking to people about their resistance to standardizing and being aware of that and explaining why we're trying to standardize. Next slide. And then finally, we did some communication reflections and lessons learned. And you can see, again, beneficial peer-to-peer communications, always an opportunity to do more communication. Be real in the messages. The suggestion, the advice that we received was don't sugarcoat anything. Talk and share things as soon as you know them and as real as you can talk about them. And then I'll turn it back to Stacy. Next slide, please. Oh, sorry, I think it's back to Doreen.
Yeah, thank you.
Okay.
Okay. In addition to what's stated on the slide, relationships were developed and strengthened between DOH and local public health. It really made the difficult work fun. Very proud of the selfless work of the participants for the good of the order. They used data, process improvements, and we were able to move past personal impacts that would occur as a result of these proposed system changes. And I think what's most important to me is that local health was grateful to be part of this system redesign. And I'll let Michelle bring us home.
Great, thanks, Doreen. I just couldn't agree with Doreen more and the sponsors that this is a really positive process that really led to kind of objective and collaborative decision making together to kind of influence how did we divide up work. I think a couple of the other things I just want to call out as things that are kind of lessons learned. I think just challenging keeping momentum. We had so much good momentum as the team in our work together, but as we kind of moved towards some quick planning and implementation, just keeping that energy going and the connections going is a challenge and something that I think there's probably lots of opportunities to do more of. I just think it was really important to spend the time and allow for the time to build trust and reach consensus. That can't happen quickly, and I think in an environment where I think most of us could say we recognize there's a lot of challenges and strain between just different partners in the governmental public health system when we're really talking about limited resources. And lastly, I think also we were working within some of the stress that was just in the system and in the relationships because of lack of resources or lack of adequate resources. We were kind of leading the way in figuring out, how do we do this partnership together and how do we really plan as state and local health together. And I think part of that, there were some challenges because it was kind of new work for us to do together. And there wasn't really a good framework or a good set of rules or playbook to do this work together, which I think led to some of the challenges around like, oops, we're almost at a boundary of, can we work on budgeting and some of the planning together with just a subset of us, and just continued clarity on who's the final decision maker and some things like that that I think are work that the state and local governmental and the tribal governmental for some projects need to do around continuing to make sure we're all in the same framework around authorities and processes. The next slide, please. I'm going to just really quickly just say this going forward. We talked about, in this presentation, we've talked about the evaluation of our process. We also have an evaluation that's already started around the implementation of this work, which really started July 1. That includes more customer feedback from both local health and my staff here at the state level, and from the providers, from the customers for this work. So that's a presentation for future years as we keep moving through that evaluation process, which will hopefully inform what's working and where do we still need to be making adjustments. And with that, I really want to open it up for questions or others. And so applying the quality improvement tools to help us move towards objective decision making is really powerful and helpful.
Great, thank you. Next question, how did you handle turnover with team members? And I'll just open that up to the panel.
Stacy, do you want to start as kind of our main facilitator?
Sure. I think the first thing we did is when turnover happened was to recruit a replacement. So some of that work happened. So the turnover in the facilitator was a piece of it. So I think the key thing there was getting people on the same board, on the same page, doing a little bit of teamwork building at some of the meetings. And then over the course of it, because it was a lengthy process, of course, there was turnover that occurred And it was kind of a combined effort of the facilitators reaching out to make sure that the incoming person had a grasp of what had been happening in the project, had the charter. I think Mary, as the project lead from DOH, also had phone calls. So kind of the personal touch and helping make sure that people understood where the project was at and what their role on the project team was. Anything you'd add, Michelle?
I just think as a collective, revisiting to, you know, as what your goals are and kind of what your ground rules are and your commitments, that framework, I guess, kind of the agreement, the team agreements and team charters. Like, I think you need to revisit that on a regular basis, both whether or not you have new members or not.
Yeah, I guess I would add, you know, we had a lot of webinars to keep the project moving forward, and we very intentionally, at every meeting that we had, showed these were the project goals, this is where we are in the phases, this is the progress we've made. So just keep kind of hammering that in. Why are we doing this work? Where are we at with this? What's coming up? I think was also, yeah, really helpful.
Okay, thank you. I have one more question, and we have a little time, so I'm going to put this out to each
Administrators, I think they could have had a larger role in the communication.
Great, thank you. And Stacy?
I think that I'm the last up. Going back to some of the recommendations or the findings from the team debrief, I think one of the things that got a little blurry in the process was the actual decision-making authority of the team. And I think in hindsight, as the facilitator, I would have added that, a slide on that to every time we had a meeting, just reminding people that the job of the team was to come up with the best recommendation, but the ultimate authority to make the decision had to fall to DOH because they were the ones responsible for the contract work to CDC. So I think in hindsight, just making sure that that was really clear, because it got a little blurry with the level of investment of time that people made and the commitment and the level of thought that was in those decisions or the recommendations and the commitment of the team to make it come true. So.
Okay, thank you, everyone. Before we turn it back over to Maria, can you go back? This
Here. Hi.
Oh, well, bummer.